adults. So just with regards to some of my background, as what Olivia has hinted, is the fact that I'm still currently working in an inpatient setting, as well as run a psychotherapy clinic. And a lot of my experience comes from actually working on the ground. And with Spectrum, we have also been involved in research. So very excited to be doing this. Thank you. Next slide, please. So I'm going to go very quickly straight into the space of giving you an overview. I just realized that my computer cord is not turned on. Just give me a second. Yes, power is back on. All right. The aspects that I would really want to cover about what stands out with the older adult population is the fact that a lot of things do appear similar. And there's often, a sense of, does it not burn out over time? And why is it, even featuring in the older adult space when things you would think would be more settled? But what we have discovered, is the fact that things change and life changes in that older adult space. There is much more grief, there's much more loss. That can actually signal out for people to become unraveled in their emotional space. So the myth that personality disorders actually burn out over time is actually just a myth. It can reemerge. It can sometimes present for the first time. And that's also something of interest in our research work. The challenging behaviors arising from personality disorders in this part of life is really about the impact it has on the quality of life and care. So we are, looking at, as the slides go on, of how this impacts not only the person with the personality disorder, but the people around them, the carers. So it could be in a residential aged care setting in terms of the staff there, or it could be family and friends who have to now work around that space and include risks as well. So so let's move forward. Next slide, please. Yeah. So the prevalence of personality disorders, particularly with BPD in older adults, we're looking at about 10 to 14% in the community. And interestingly, research shows us that above 50% actually in aged care settings show elements of personality traits. What we see is that the common ones tend to fall under these categories of obsessive compulsive, definitely some very clear narcissistic threads, and a dependent, anxious dependent sort of cluster as well. So having a personality disorder actually may also signify a higher risk in the way of mild cognitive changes and looking into dementia that becomes more exacerbated for people who already have a personality type that does not allow for them to be cared for in a very supportive manner, because of the fact that they tend to be more seeking of attention. Yeah. Next slide, please. So the aging trends and personality traits, as we said before, interestingly, even for younger population, we know that sometimes we don't have a very exclusive element of only sitting in cluster B. What we realize amongst our older adults is that sometimes you have an overlap, and you may have traits coming from cluster A, B, or C. And what we see particularly is that in the cluster C side, as I said, the anxious, avoidant, and dependent threats tend to be more pronounced. And this then adds into the rigidity. And what we find then is that their way of thinking becomes very concrete, which makes it harder then for the caregivers and family to actually try and create change. So that is something to be putting in the background, because when we talk about actually working in a therapeutic way with regards to working with older adults, it may be slightly different because we don't have a paradigm currently that we actually use in older adults. in my own experience, I've had to be eclectic in my approach, and I'm still exploring, paradigms that are going to sit for longer term therapy work. But to also understand that because of the natural cognition impact of people sometimes not being as cognitively aligned as they were in their younger days, what we have is that then actually impacts on their ability to actually compensate into new coping styles. And adapting to changes and interpersonal relationships, especially where there's been a loss of the primary carer or the primary attachment, can then cause very, very dramatic changes in their presentation. And then we also have to take into account the cohort effects. In my own work, I've realized that the Stoic generation, is quite different in its presentation compared to the baby boomers currently, and their sense of being more entitled and more expressive in their needs. And definitely people in residential age settings, especially the caregivers, will find that is a huge visible difference between the different cohorts. And so something for us to also take into account. Yes, thank you. Next slide, please. So with regards to actually the factors contributing to what we would consider as the main changes in older adults, we have, number one, the increased medical comorbidities. Sometimes they are existing and chronic, but we also have many older adults coming into new diagnosis, whether it's to do with pain, whether it's to do with neurological changes. We have that to cope with. Then they have also polypharmacy excess, and the medication and side effects may also, impact upon this older adult group, which makes it then harder. And also with regards to risk, this is something to hold in mind because of the fact that they have access to different types of medication and potency. Then we have the psychological changes that is unique to older adults. So the cognitive decline, particularly where that the ability to learn new skills is much more is lesser in the way that you have to have repeated time and patience to actually move them into that space of actually learning new coping styles. And the other aspect is existing mental health conditions. One of the things we know for sure is that older adults, particularly with depression, tend to do worse when it comes to them being able to impact their quality of life issues. So when it comes to personality disorders, we also find a huge component of mood disorders featuring in them. In the social side, the challenges are really into the aspect of working with change. So when they downsize and they have to consider, going into a residential age facility, that can be a huge impact. It's the adjustment aspect to it is actually much more pronounced than what we would think, that it would be a clear-cut sense of the person actually wanting to move into this space. Many a time they are almost forced into this space, and they haven't come to their own realization that they are unable to support themselves. And when families around them are already burnt out, and it becomes one of those things that there's an appeal to the hospital system to actually move the parent into a residential aged care facility, that can bring about much more conflict and much more grief. And the losses. It is very real that for any older person, they're going to definitely go through more illness, more losses in the way of friends, pets, spouses, passing. And how this then figures in them can have a huge impact on who they are and how they see the world. Yeah. Thank you. Next slide, please. So, as I mentioned, mood disorders, particularly depression, is something that, features in most of our older adults with personality disorders. It's one of the main areas where we target when it comes to actual treatment. So this is where we're talking about the pharmacological, sort of input first, because of the fact that someone depressed may come across as more rigid, more concrete, more withdrawn, and therefore do we treat it as a personality type, or do we actually understand that it is actually the depression making them that way? So it is really important to first address that and then seek that collateral history to try and understand who they were pre-morbidly, so that we can then work out their personality type. And, when a person is already had or has had a history of not functioning well with change and with relationships, the aspect of depression can then exacerbate all of the other issues and complicate treatment as well. And we also have found that anxiety features quite commonly amongst our personality disordered patients. However, we haven't done real major studies around that. And, we work with it as still as what we would do in any other presentation in looking at anxiety. But anxiety actually, particularly with the cluster C, where you have the dependent traits and the spouse has, passed on, you find that it becomes really very tiring on the caring, system in terms of how to provide that reassurance. And so this often becomes a major issue in residential aged care settings. Yeah. So diagnostic challenges. Now, this is a very important part in the older adult space, in the sense that we're looking at someone in their 70s or 80s and thinking about how do we track this? How do we actually get to a point where we can actually make that diagnosis? So it is complex. And often what we understand is that, we lack several aspects to actually sometimes having access to collateral history. We may not actually have them been diagnosed with a personality disorder when they were younger. So the existing diagnostic criteria is actually not set up to pick up necessarily how it features in older adults. And with the clinicians too, often, we find that when they become treatment resistant, with either the depression or with the anxiety, and clinicians then turn to the fact that, okay, what are we missing out here? Clinicians generally find it difficult to actually put out the personality disorder diagnosis because of the fact that it carries with it, even in the older adult space, a negative stigma. And it's more difficult to explain to them about a personality dysfunction and the fact that, we don't really have a paradigm to have treatments put under. So, and with all the comorbidities that we are working with, it's so easy to get carried away with, let's treat the physical side, let's treat the depression, and then, but what happens to this personality element? Yeah. So that's where it is important to realize that diagnostically, this is a challenge. And perhaps at this point to also say why our research has come into being, as in to try and fill this gap and try and create a screening tool that actually can pick up the uniqueness of how borderline personality disorder, for example, features in older adults. So that's a space that if you had more questions later on, Gillian is here too, and we are all working on this project together. Yeah, thank you. Next slide, please. So I think I've covered most of this, but what's important post actually having a diagnosis is to actually be able to sit down with the client and with the family to be able to communicate this. And what we have found is that for many of them, that's not been a space that they have even thought about. A lot of families that we have worked with have actually provided such a sense of relief in those meetings when they actually hear that some of what they have been going through for many, many years in terms of the splitting, in terms of the, sometimes the manipulation, sometimes not understanding the expression for more attention, and all of that as being part of that personality space. And so for us, then it becomes a major, priority to sit down and educate the family and the patient, and to actually talk about what that means for them in life, as in the present. And so this is important for us to actually understand that this is a priority. So it really begins with providing that diagnosis and sitting and actually talking about that. Yeah. Next slide, please. Okay, so the current assessment tools that we do have are really meant for the younger population. But we have looked into PAI, which does say that it is valid till 89 years. However, it's a very long, complex, it's got about 346 questions. And in my entire, recent career, I've only had 2 clients who have been able to actually fill that over a period of 2 or 3 days. So you're not going to get any of these standardized measures necessarily, because of how long they are and how difficult it is to get someone to actually sit there and fill them out. Now, we do have some research in this space, mostly in the Netherlands, and and we are spearheading something here in Australia, where there are other personality scales that we can use in our older adults. They're all listed here, and when the slides come around, I'm more than happy for us to share some papers on those 3 questionnaires. Yeah, thank you. So the benefits of diagnosis, as I said, the relief for families, particularly, to know that this is not all depression and anxiety, but there's something more that has been going on. And the reason why some of them see things differently, even amongst, a group of children. And, mom or dad could be aligned to one child, but not another. And then that can be then used to create more conflict in the system. And this happens also in nursing homes, that, sometimes our older adults with personality disorders may align themselves with a certain staff member, and then use that to actually then create conflict or splitting with the rest of the system. So being, valued and devalued are all things that can come up over and over again. So the aspect of diagnosis is really important and accurate. In our inpatient setting, we actually create not only risk and safety plans, but a positive engagement plan, which helps caregivers to actually understand how to approach this person and how to actually keep them sometimes, contained with certain emotionally dysregulated behaviors. So, this really helps then to facilitate better health overall. And it also validates, like I said, the behaviors and the chronic fluctuations for the patient. Thank you. Next slide. Yeah. Okay. So in aged care settings, which I've hinted at, throughout the speech or talk so far, is the fact that we do have more than 50% of our older adults sitting in that space showing definitely traits of some personality, I wouldn't say disorder, but traits of them that can be exacerbated. And so it becomes difficult, particularly in a residential aged care setting, because you have staff that are on shift and not necessarily trained to work in this personality space. And so they do become burnt out, or they try and avoid those patients or clients or residents because of the fact that they don't know how to approach them. And so it does become a common reason for referral, especially to our community aged care teams, to go in and actually work out what's really happening. And in the context of cognitive decline as well, because we know that there's often some personality changes and some rigidity and some concrete ways of thinking, that this then exacerbates the idea of what was this person pre-morbidly. Yeah. And so it is so important that we actually work with that pre-morbid part and then use that to also understand what are the current challenging behaviors. Thank you. So what we know is that for a person presenting with a personality disorder, what we have is these sorts of very important or very pertinent behaviors. You have increased sensitivity to emotional pain and definitely interpersonal interactions that seem quite disruptive. We do see frequent fluctuating moods. This is where even a small, new diagnosis, for example, of, say, a wound may actually bring out an exacerbated distressed crisis. You do have older adults expressing death wish, but importantly, being mindful that it's more lethal when they do attempt. So suicidal behaviors still have to be something that we manage in this space because we have known of residential aged care clients who have been hoarding certain medication when the nurses leave it to them to take it themselves. So it is still important to have the same protocols that you would have when dealing with someone in the community. And you will see sometimes the confusion because of the fluctuating moods that the same person can still also be happy, after having a conflict. So something's not right. Yeah. And then the excessive seeking of attention and support from staff. We also see that we can have elements of irritability or anger that's thrown on in the way of carers and support staff, and often that will also put staff off to withdraw, and their expectations being very excessive or unrealistic. And the overall poor network of support means that you have less visitors coming into residential aged care settings, which may then also set them off with other residents who are having more families coming in. They also then have lesser, sense of quality of life because of the fact that they're not socializing as much. So residents then become dependent on staff. And this then means that they over idealize and they look forward to staff and may demand more time of staff because their own families are not there for them. So, personality disorders do cause immense distress for the person and for the people who are caring for them, who are torn in terms of what more can I be doing? How do I make this all go away? How do I work with this to actually feel like they are supported and I can cope with what's happening here? Yeah. Thank you. Next. Yeah. So, what's important that we have found, and as I've mentioned, is the socialization aspect. The practice of actually being able to maintain a relationship is just as important. And we find that residents who are given some meaningful tasks, tend to actually feel better. It actually helps to feed into their sense of actually having a purpose. So, for example, if there are activities and groups being run, they could be given that element of facilitating, say, a bingo group in a residential aged care setting. It feeds into their element of actually feeling that, there is a purpose. And also being able to collaborate with the resident and actually say, look, we're seeing that you are having, these periods of crisis and distress, and we don't know how to help you when you are in that space. So how about we sit down and work out what is going to work for you and how often you are able to approach us as staff to actually seek that support. So trying to work with them a plan out is actually the best way of managing this. And the antecedent, I think sometimes it is so easy, especially with shift work, to actually not have been informed of something that's happened in the morning and therefore the resident continuing to behave in a certain way. So communication among staff is just as important. And it's the same in the community. Families, for example, when they don't talk enough to each other, may be sitting with a type of reaction from an older person without actually understanding the context. And so it is so important to not feel or give in to actually us withdrawing and then neglect setting in. And so we've also found, like just typically with all borderline patients, that sensory based soothing techniques actually work very well. And particularly when we have people going into dementia as well, we do find that these sensory-based soothing techniques work very well for them. So this is like in the way of, if you know that they have had a pet before, and actually having those, beautiful objects that the occupational therapists would be very familiar with, that, look almost like a real cat or a real dog, and dolls. These have all come into that space. And distraction and relaxation skills. Now, this, I would think, that is something that often gets missed out on. People tend to minimize how important it is to have those calming moments during the day. So it is important for an older person to not feel like that's something that they have to do on their own. They often do well when it's done hand in hand with somebody. So if you were going out for a walk with the person, that really makes a difference. If you sat with the person on a bench on a beautiful sunny day and say, how about we both do some deep breathing now? That works better. And just checking in with them, and often it is about, having that afternoon nap that can make a difference to them. Yeah. Okay, next slide. So with our own self-care, in terms of us working with them, it is important to set up those boundaries. And it's easier when you actually put that in right from the beginning, when you know that you are working with someone with a personality disorder, particularly around your availability and how much of support, whether it's by time, that you are limited. And it's also important to define your professional role, because you often will find that they will come to you for, say, medical reasons, when that element of medication is not something that's in your control. And so it's very important to be consistent and predictable so that they don't get confused as well. And having clear care routines for them, and very important, because they often will play up on that. And neglect can sometimes take over when you actually tend to withdraw from this space. And planning the task with regards to what you're actually going to do with them, spelling it out to them that our session today is going to be about this, this, this. And of course, there are going to be times when there are going to be moments of crisis, and being available in those times, but still being fairly flexible with boundaries, but still having those boundaries are important. And then, of course, you need to feel supported. You need to belong to a broader team, and having that element of actually being able to talk to a peer or checking in with, the system. So, for example, if you're going in and actually doing a consult and coming away, still being able to talk to the actual care providers to make sure that what you're thinking is in line with what they can actually do, in terms of action. So with families, it's the same sort of advice that I've given to us as clinicians, that we will be actually taking with families, to be actually non-judgmental with how they are feeling, to actually allow them to feel that sense of, validating their distress, and taking away the element of guilt or stigma just because family have been diagnosed with a personality disorder. So it all, is in the way of looking after the system. So self-care for both the workers, but also for the families. Yeah. I think I should be finishing up soon. Yep. Okay. So these are things that I've already mentioned, but I think it's still important for us to know the pathway at the moment, that if you are coming across an older person with a personality disorder, how quickly and whom to send them to with regards to getting more support. And of course, for us too, to be able to actually get more professional development learning around how we work with this. Yeah, next slide, please. So we have published 2 papers in the research that we have done, and very, very happy to send those papers to you all for further reading, if that helps. Yes, and more resources. So we've got Spectrum, and we've got the BPD Foundation that still has help for carers, and that's not limited to not age limited. So yeah, anyone with even older adults and families having need for further support, please get to the BPD Foundation. Yeah, thank you.